Welcome to Medicus Aeternus, where the journey to mastering medicine never ends. We are here to make learning easier, more enjoyable, and to help you excel in your medical path. Let's dive in and learn something new today. Today, our topic will be an introduction in general pharmacology, basic concepts, basic terminologies that you need to understand and master in order to be able to understand pharmacology, as we will move on during all these concepts, all these particle, everything that will go around. So in order to everything be understandable, you need to understand these concepts and master them as much as possible. Today we will talk about a first part of pharmacodynamics, so let's go on. First, we will analyze some basic concepts. What is medical pharmacology? What is clinical pharmacology? And so on. Well, medical pharmacology, as the name suggests, it's a study of how drugs interact with the body, how they help in treating diseases, making some improvement, and so on. But clinical pharmacology, it's, as its name suggests, it's how the drug interacts with the human body, how it helps to alleviate pain, how it helps to cure some disorders, some diseases, and so on. And as physicians, as doctors, we are more concerned about clinical pharmacology. We have two main terminologies, two main concepts: pharmacodynamics and pharmacokinetics. What do these two mean? Well, as you can see here from the illustration, that pharmacodynamic is the effect of the drug on the human body. What does the drug do when it enters the human body? There are two main concepts belong to this topic. You have the metabolism and the effect. The metabolism is how the drug works, the mechanism of the drug, to which particle they interact, to which receptor, which enzyme they inhibit, which enzyme they stimulate, and so on. And the effect is what is the result of this inhibition, this stimulation, and so on. So to give an example, for example, we have drug ACE, the ACE inhibitors. These are drugs that are used to treat hypertension. The mechanism is that they block a specific receptors, block an enzyme, and as a result, this is their metabolism. But the effect, the blood pressure will drop and the blood pressure will be controlled. However, when you go to the next topic, which is pharmacokinetics, as you can see, is the other way around. The effect of the body on the drug, some like to explain it as the journey of the drug inside the body. And for this, there is that mnemonic you can use, the ADAM mnemonic, ADAM. A stands for absorption, how the drug is absorbed and to which percentage is absorbed, and is it water soluble that it can use as an oral, or is not, it can use only as an injection, and so on. And D, we have distribution, the distribution of the drug. Does the drug get distributed in all the tissues of the body or no? Is it able to cross like the blood-brain barrier, for example, or the brain barrier between the testicles and the blood vessels or no? Is it able to cross the placenta or no? This all. M, it stands for metabolism, which is the way that the drug gets metabolized, whether in the liver or not, and what will happen. And E for excretion. Is the drug gonna be excreted as itself or as a metabolite? And will it be excreted through the kidney or through a sweat or whatsoever? Well, here we need to understand that for a drug to interact, it needs targets. And these targets, there are many targets actually, many targets, but we are concerned with the four big targets in which the drug, by interaction with them, an effect will come. You have receptors. And receptors are divided into types. We will discuss them later. You have ion channels, you have enzymes, you have carrier molecules. Well, ion channels, they are usually a part of the receptor. Usually these are molecules, particle molecules that stand in the top of the receptor, which the drug makes a bond with it, and by bonding with these channels there will be some interaction and changes which will help for the effect of the drug to come along. The second one will be the enzymes. How the drug can affect enzymes. We have four types. First, you already know that enzymes are proteins that are help to catalyze a reaction. Any chemical reactions, biochemical reactions, they need enzymes. Without enzymes, a chemical reaction that would take, let's say, a minute, it would take hours, days, or even years. So enzymes are crucial. Some of the drug may act as a competitive inhibitor, which means they inhibit the action of the enzyme, but this is all based on concentration. If the concentration of the drug becomes more, it will inhibit the enzyme. If the concentration decreases, it will no longer be able to inhibit the enzyme. And the enzyme structure, you already know it has a main site where it bonds with the proteins, and it has a substrate site. Such as example of competitive inhibitor, we have a methotrexate. Methotrexate, it's a drug used as an inhibitor of the immune system. And the second one is the drug that may act as an irreversible inhibitor, which means that it doesn't matter about the concentration of the drug. Once it binds to the enzyme, it never let it go. And as it binds, the inhibition happens and the enzyme remains inhibited. And such an example, penicillin. The third one, a drug may act as a false substrate for the enzyme. An enzyme, when it binds with any molecule, that molecule is called a substrate. And this drug can fool the enzyme, let's say, and binds with it as a false one. And an example is methyl dopa. The fourth one, a drug might induce or inhibit the hepatic macrosomal enzymes activity. We have already discussed in pharmacodynamics and pharmacokinetics that for a drug to be metabolized, like there are a huge majority of drugs metabolized in the liver. And some drugs, they might act on these enzymes, such as P450 enzyme in the liver. For example, phenobarbital. This drug acts on these enzymes and might cause this kind of reaction. The next one, we have carrier molecules. What do you mean by carrier molecules? For example, you have a cell, all right, and this cell has a receptor. This is number one. You have an ion channel. You have enzymes, which we already talked about, and those enzymes can be intracellular, extracellular, and so on. Carrier molecules are molecules that are located outside the cell, and for a drug or a molecule whatsoever to enter inside the cell, these molecules should bind with these carrier molecules in order to be able to enter inside the cell. For example, glucose. Glucose, they need transporters in order to be transported inside the cell. And targeting these carrier molecules with the drugs, you can inhibit the absorption of glucose, or you can enhance the absorption of glucose, depends on the desire that you want to achieve. We have discussed the main four targets, but the most important thing we need to talk about are receptors, because these are the main thing that drugs interact with and the effects that we want to see in our patient. Well, as a definition, like a simple definition, receptors are protein molecules that are across the cell membrane. You know, the cell membrane is made of lipids, and these receptors are proteins, and they have extracellular part and they have intracellular part. The drug usually interacts with the extracellular part and cause, for example, to this receptor opens and another molecule enters, sodium, calcium, or so on. Or they can interact with the extracellular part of the receptor, causing a chain reaction and secondary messengers that can have some changes inside the cell, and the desired effect can be obtained. Any molecule, whatever it is, a drug or whatsoever, that binds with the receptor, it's called a ligand. And the ligand, it comes from the word ligation, in which it will be kind of a connection between that molecule and the receptor. And if the ligand combines with the receptors, and the result would be like stimulation and enhancing or whatsoever, is called agonist. But if the ligand connects with the receptors and it just blocks the action of this receptor, like after this ligand connects with the receptor no longer works. It's like out of the network. It's over. It doesn't work. This is called antagonist. And for a molecule to bind, we have, let's say we have molecule A, you have molecule B. Molecule A can bind with the receptor in a much faster way and better than molecule B. And molecule A can occupy all the receptors. Like, for example, let's say that this cell has 4 receptors, and molecule A is able to bind to all 4 of them, while molecule B can only bind with 2 of them. We say that molecule A has more affinity to the receptor. Affinity is the ability of the drug or the molecule to bind with the receptor, and the strength of this connection. And the receptors, we have 4 main types. We have the ion channel linked receptor or direct ligand gated ion channel receptor. Here, for example, the musculoskeletal receptors between the skeletal muscles and the nerves. Acetylcholine comes and binds with the receptor, causes some changes with the receptor, and the receptor widens up, and the sodium rushes inside the cell, causing the contraction of the muscles, and so on. These receptors are the fastest one to work. It works very fast. The receptor opened very fast, and the response is you can notice it at once. The second type, which is the most common in the body, is G protein linked receptors. And these receptors, they can be divided into 3 main ones. You have GS, which is G protein linked stimulatory, and when the drug interacts with this kind of receptors, they increase the CAMP. CAMP is a secondary messenger inside the cell. As I told you, we have extracellular and intracellular, and let's say that this one is GS type. You have the drug interacts with here, causing chain of reaction. This chain of reaction leads to the stimulation and the increase of CAMP. CAMP is inside the cell, intracellular, which acts as a secondary messenger. And this one, CAMP, will continue the chain of reaction and will cause an effect. The second one is GI, G inhibitory. So this one is G inhibitory. Here the drug interacts with the extracellular part, causing some reactions. Then inside the cell intracellular, these reactions will cause the decrease of CAMP, and as they decrease, the effect will not be met, and so they are called G inhibitory. The third one is GQ, and Q stand for questionable. Some of them, they can act as a stimulatory, some of them act as an inhibition, and so on. The third type is tyrosine kinase linked receptors, and these receptors, they have domain, as here it's shown, extracellular domain. It's also called alpha domain, an intracellular domain called beta domain. And usually this beta domain is linked to tyrosine kinase enzyme. And this extracellular, where hormone connects, and the most clear example for hormone that binds with this kind of receptors is insulin. Once insulin binds to this receptor, there'll be a chain of reaction that will activate tyrosine kinase enzyme and so on, and it will help to meet the desired effect. The fourth type, and the most interesting type, is intracellular receptors. These receptors, they are also known as nuclear receptors because their work is different. Here, the molecule should enter inside the cell through a receptor. For example, we have steroids like corticosteroids, we have hormones that are stored like estrogen, for instance, testosterone, and so on. And once a hormone or a drug binds with these receptors will work by changing the expression of the DNA. And by changing the expression of the DNA, we will have the effect that we wish to meet. And these effects, they can be met, but the point in these intracellular receptors that, because as I told you, the work is by expression of genes. So the effect to happen, it takes time to kick in, to start. Unlike the ion channel that starts very fast, it takes time. But once it happens, it's prolonged action. It lasts for a long time because you have already altered some expression of genes. That's why the effect lasts for as long as possible. Well, we have dived into the receptors, type of receptors, and how they interact with the drugs and so on. Well, for a drug to attach to a receptor, they need some bonds, and these bonds are like, you can say they're like bridges that connect between the drug and the receptor. We have three main bonds. First one is hydrogen bond. And what is hydrogen bond? For example, a drug has a hydrogen ion, and the receptor has oxygen or nitrogen or hydrogen. And a bond between hydrogen and hydrogen, oxygen, hydrogen, and nitrogen is called a hydrogen bond. And as you know from biochemistry, that hydrogen bond is a strong bond. And usually these drugs that use hydrogen bond as their mechanism of interaction with the receptors, their affinity is high. And affinity, as we have said, that it's the ability of the drug to interact with as many receptors as possible. The second one is ionic. And ionic, which means that the drug has a positive ion and the receptor has a negative ion, or vice versa. And as you know from basic physics, that positive and negative different charges, they interact with each other, they attract each other. And this bond is strong, but it is reversible. And this is a very important idea, which means that if you give a different kind of drug and that has more attraction, more power, it can interact and replace that drug. So it's strong but reversible. The third one is covalent. Covalent, as you know from biochemistry, organic chemistry, you have two atoms and they have the last shell, they have not enough number of electrons, so they share electrons. And as they share electrons, they become much more stable, and that's why their connection will be strong and at the same time irreversible. Unlike the ionic, it's irreversible. That's why when a drug interacts with a receptor in a covalent bond, that drug will still be intact with and will be in touching with the receptors, and the only way for the body to eliminate this one is to get rid of the drug and the receptor all together and synthesize a new receptor. We have already discussed the receptors, type of receptors, the targets, carrier molecules, enzymes, and so on. Now the main question is, what is the response that we can reach when the drug binds to this receptor or that receptor. This is called the biological response to drug receptors binding. We have two main types of this one, with either an agonist effect, in which the drug, when combined with the receptor, it gives a specific response, or antagonist effect, which means that the drug, when combined with the receptor, it gives no response and prevent the receptor from binding, like it puts it away, out of action, out of everything. In this video, we will talk more about the agonist effect. And the agonist effect, it's usually divided into two main types: graded response and quantal response. And from the name, you understand that graded, it's like gradual, and the response is based on the dosage and the concentration of the drug. As much as you increase the concentration, the response increases. So for example, if you have here a diagram and you have a drug and a receptor, and you have the drug, for example, you give it in a 5 milligram concentration, and this drug is like, the main action is to decrease the heart rate, or decrease the blood pressure. You give a 5 milligram and the decrease happens, like for example 10%, and this is a good response. You increase the concentration to 10 milligram, it decreases 25%. You give it to 50 milligram, it also decreases to 50%, and so on. So as much as I increase the concentration, the response increases at the same time. But that doesn't mean it will keep increasing until forever. When you increase the concentration, it will reach a maximum point. It will create a plateau. A plateau is, it's like you reach the maximum effect possible that drug in that concentration will give you. No matter how much you increase the concentration, the effect will not be at all. It will be the same. You have reached the maximum. And this maximum effect is called efficacy. And the only thing that you will get from increasing concentration beyond the efficacy is toxicity, and you will have a huge side effects and toxic effects. Whereas quantal response, as its name suggests, it's based on quantity, and I'll explain how it happens. In quantal response, the main idea is all or none. Either this drug with that concentration will have an effect, or it doesn't have effect at all. For example, you have arrhythmia. The drug in that concentration will stop the arrhythmia, because arrhythmias are serious medical conditions. Or that drug, it will not help at all. It doesn't mean that if I give 5 milligram of that drug and the arrhythmia will get better. No, the arrhythmia will not get better. It will stay the same until I hit that concentration that I need, or that concentration that is needed, and the arrhythmia will stop. So it's either all or none. And quantal, they take it from, the experimentation. It is usually done on the animals. And they take, for example, 100 rats, for example, and they do this experimentation on them, for example, to treat arrhythmia or epilepsy. And they give a dose. And for this dose, only 5% of these rats benefited. They give 10 milligram, for example. They increase the dose. And from these 100, 30 of them gets better, until they reach to a concentration, let's say for example 20 milligram, in which 98%, almost all the rats, are benefited from that drug. So here we reach the Emax, the efficacy of this drug. And most of the drugs, they work based on the graded response. Only few of them work on the base of quantal response. And agonists, they usually are two types. You have a full agonist and partial agonist. And this classification is based on the efficacy. For example, you have two drugs, drug A and drug B. Drug A can reach to the Emax and they bind to all receptors. While drug B, for example, it binds to all receptors but doesn't give the Emax. For example, its efficacy will be 60%, 50%, 70%, not like the drug A, which gives almost 98% or 100%, let's say. So that drug that has a high efficacy, it's called full agonist. The one that has low efficacy, it's called partial agonist. The next terminology is potency. What is potency? You might read in textbooks and you find terminology called ED50, which is the dosage that gives 50% of the effect. We have Emax, the highest possible ever, and we have 50% of that, the effect that we need, 50%. And during experimentation, I find that dosage that gives 50% of the effect. Now this concentration, this dosage that gives 50% is called ED50 or called potency. And you have two drugs, drug A, drug B. Drug A, for example, it gives a 50% of the efficacy. It gives ED50 at a concentration, let's say 7 milligrams. While drug B gives 50% of the response at a concentration of 40 milligrams. Drug A gives it in faster than drug B. That's why drug A is called more potent than drug B. When you read and you see that, for example, this drug is more potent than that drug, it means that the drug that is more potent, it's able to reach to the 50% of the maximum effect in a low concentration compared to the other drug. And for graded response, the drug that gives 50% of the response, it's called potent. But for quantal response, because we know quantal response, it's all or none. It's not about the effect same as in graded response. In quantal response, potency is defined as the concentration that is able to prevent the disease in 50% of the tested subjects. You have, for example, 100 rats and you test on them a specific drug for arrhythmia, and you reach a specific concentration that prevents arrhythmia in 50% of them. Then this is the potency, okay? The next one, we will talk about a therapeutic index. Before therapeutic index, let's talk about toxicity. And in toxicity, we have a specific term. We have LD50 or the lethal dose 50, which means that what is the concentration that the concentration that is it reaches to a specific kind of response and can cause a drastic side effects that could be lethal. And that concentration, that when we hit it, it will be lethal to 50% of the tested subjects. For example, you have 100 rats, again the same example, and you give them drug for arrhythmia, alright? And if that concentration, for example, let's say the concentration is 20 milligrams, and in this concentration, this 20 milligrams, half of these rats die because of cardiac arrest. Now, 20 milligrams will be recognized as LD50. It's the lethal dose. And, for example, that drug, specific drug, it has a potency, the ability to give 50% of the maximum effect, let's say at 10 milligram. And it has LD50, the lethal effect, at 40 milligram. You take LD50, you divide it by ED50, the toxicity over the potency, and you have, for example, 40 over 10 will be 4. This number is called therapeutic index. So therapeutic index is LD50, the lethal effect of the dosage of the drug, over ED50, the potency of the drug, and the result will be therapeutic index. And this is very, very important terminology. The wider the therapeutic index, the more, for example, if the number comes like 20, like for example 100,000, this means that this drug is safe. The higher the therapeutic index, the safer the drug is. And the drugs that have high therapeutic index, they call them that this drug has wide therapeutic index. But as the therapeutic index is low, the wider, the smaller the number of therapeutic index, it means that the drug is not safe and it has narrow therapeutic index. For example, warfarin. Warfarin, it's a blood thinner. It's a drug that is used to for people who have like to prevent atherosclerosis and so on. And warfarin has a very narrow therapeutic index, which means that you have to be careful because the dosage that gives maximum effect and the dosage that is lethal, they are not that far away, and the number is small, so they can have such effect. Thank you for watching Medicus Aeternus. Remember, the journey of a medical professional is eternal, and we are here to guide you every step of the way. Don't forget to subscribe, hit that bell for updates, and show some love by liking and sharing this video with your friends. Stay awesome, keep learning and thriving.